Hello friends, I am Dr. Tiwari. I am trained in critical care medicine and practicing it since last 20 years. So today's session, I'll be introducing you a very important neurological emergency, status epilepticus. It has got a high morbidity and mortality and high healthcare cost is associated with this neurological emergency. So the learning objective for today's session will be to understand the definition or the changing definition, try to find the practical, how practically we will define the neurological emergency status epilepticus, to define it, to understand the various causes, etiology and associated mortality, to understand the insight about pathophysiology of status epilepticus, how we will as a clinician we can predict or what are the tests which guide us to know about the status epilepticus? What is the practical management? And of course, what is the updated treatment algorithm? What this condition has in future directions? These things we are going to understand at till the end of this session. So let's start with defining the status epilepticus. Now, practically, if we see that these definitions have come from the International League Against Epilepsy Foundation, which stress the importance on duration of seizure. So initial definition was when the duration of seizure lasts more than 30 minutes, then they called it status epilepticus. But this definition is highly impractical and later defined as the prolonged seizure or series of seizure with incomplete return to the baseline. When the patient doesn't return the conscious level between the two seizures, it should be the physician should start treating it as a status epilepticus, because we know that the risk of neurological injury starts to increase as the treatment for seizure is delayed. At the same time, the pharmacoresistance also increase. So the treatment of convulsive status epilepticus should start within 5 minutes of seizure onset. This definition can also be extended to other forms of status epilepticus, including focal seizures. You should not neglect the focal seizures. They may turn into the epilepsia partialia continua type, or if the patient has dyscognitive feature, or the difficult to diagnose like absent status epilepticus. So all this is very time sensitive, and as I said, to avoid the risk of pharmacoresistance, to avoid the risk of going into the from seizure single episode to the status, this is a practical definition which we should keep in mind. Now coming to the etiology, the most common etiology of status epilepticus, often the patient comes with the previous stroke, or as the list here shows, the first cause as acute cause, sometimes in stroke with bleed or ischemic infarct or cerebellar infarct, or patient with previous stroke with scar epilepsy. Certain patients with drug overdose can come as a seizure. Patient who have alcohol misuse, or patient with certain tumor in the past, patient with trauma, patient who is a drug defaulter or is on anti-epileptic drugs, not on regular medication, also contributes to higher number of patients who can present with stroke. Sometimes it may be idiopathic in the late onset epilepsy. So all these are the causes which can go from single seizure to the status epilepticus. What is the pathophysiology underlying? So most of the studies to understand the pathophysiology was done in the animal models, where there is an imbalance between the inhibitory interneurons and the excitatory um, neurotransmitters. So, if there is a failure of endogenous mechanism to terminate the seizure, like decrease in the activity of gamma aminobutyric acid, which is inhibitory, as shown here, or there is increase in the excitatory NMDA or AMPA receptors, and this moves from stage 1 to stage 2, stage 3, and later on to stage 4. So these neuropeptide expressions and complex mechanisms has been demonstrated equally in the non-convulsive status epilepticus in various animal models. So this is the research going on in understanding the pathophysiology, how the single seizure transfer into the status epilepticus. How a clinician should diagnose. Now, clinically, if the patient has generalized tonic-clonic convulsions, the movements, the typical movements, the patient had fits and then he did regain consciousness in between, it's easy to diagnose. That patient is having, when the patient unexplained, or where the patient is not having this movement but he is in the obtunded state in the ICU, that is the time when you should suspect status epilepticus, where there is no motor movement but at the neuronal level, and that is a non-convulsive status epilepticus or non-convulsive seizure, which can be picked up by the advanced EEG, electroencephalography monitoring, or sometimes by the imaging CT scan and MRI. So I more emphasis on the EEG in such patient who are obtunded. Of course, obtunded patient undergo the to rule out the structural cause for CT scan and MRI as well. So in imaging, most of the time it looks like as you see here, the diffusion restriction in the MRI images, and this appear as a T2 hyperintensity. Sometimes in later finding will be focal atrophy and development of hippocampal sclerosis, which is common, implies the permanent neurological sequelae. These intensities happens is often reversible if the patient is having status epilepticus. EEG, as I said, has been a major tool in diagnosing the obtunded patients who don't have tonic-clonic, but you suspect non-convulsive, and you can monitor the various waves here. And a good interpretation, you can, if the facilities are there, with the limited facilities, we can do the EEG or bedside if it is available for the obtunded patient. There is inter-reader variability, and the understanding of the EEG will require some training as for the ECG. So there is a role of extended EEG monitoring, and most of the ICUs should invest in this machine to get an EEG monitoring. These are the various studies in 2014-15 which have shown that in medical intensive care, there's 67% of chances of uh, developing non-convulsive status, where the in patients with mixed intensive care there is 92% chances, and so that stresses the importance of getting the extended EEG monitoring in such patients. Coming to the most important part, the management. The management of status epilepticus, as I responded earlier, that it should start as early as possible. So right from the pre-hospital management to prevent the neuronal damage as well as pharmacoresistance. What should be the management in emergency room? Your team should be aware of this condition. You should be aware of your drug protocol. Predefined protocol will be better, and the intensive care management. The pre-hospital management of status epilepticus, benzodiazepines has been studied. Now, the problem in the pre-hospital care management is how to give the drug. So, lack of intravenous line. So, they are studied about the buccal spray, like you give sublingual nitrate for MI. So, similarly, buccal spray or nasal spray for benzodiazepines. There has been a trial, rapid anticonvulsant medication prior to arrival trial, where they compared the pre-hospital administration of intravenous lorazepam with intramuscular midazolam, and they found no difference. So when the IV is not available, IM or intranasal preparation or buccal preparation or midazolam spray as early as possible, which can help in as an anti-epileptic rescue medication by the family member under supervision of first responders. However, these patients should be kept in lateral position or should be kept in recovery position, should not have aspiration or other complications prior. So this also is important in the pre-hospital management after drug treatment. In emergency room, again the emphasis on the proper oxygenation, airway and oxygenation, breathing, maintenance of circulation, monitoring, most important, BSL, blood sugar level is a part of physical examination, should be done, and these patients should receive thiamine and should be given before concurrent to avoid depleting store of uh, thiamine. So you should check the sugar as well as assessment and prevent the Wernicke's encephalopathy. So these tonic-clonic seizures are often associated with a lot of metabolic acidosis and apnea, and that's why the airway is a prime importance. If the patient is obtunded, there is a tongue fall, there is airway obstruction, they may require intubation for airway protection to prevent secondary complication of aspiration. And also the focus should be on rapid treatment or termination of the seizure activity, because if the seizure persists, then it can lead to resistant status epilepticus. Coming to updated treatment algorithm of status epilepticus. Now, this is the most important algorithm or protocol which can be followed in the hospital in the emergency room. Once you have done with your airway, breathing, circulation, and intravenous thiamine and dextrose, sending the lab test, hydrating the patient, shifting before shifting. The initial drug of choice, as I said, was the lorazepam. The dose is 2 to 4 milligram, can be repeated. It causes less of respiratory depression and prolonged half-life compared to midazolam, which can be also given as an intramuscular if required and can be needed. 10 milligram can be given. While these two drugs are immediate to act within 2 minutes, they are to prevent the seizure activity. We have to give anti-epileptic drug to prevent the recurrence. The two drug which is age old is phenytoin, which is 20 milligram per kg. For a adult to 50 kg, around 1000 milligram has to be given. The major concern with the phenytoin is you cannot give it more than speed of 50 milligram per minute, because it can lead to arrhythmia and hypotension if we given fast. Similarly, if you want to administer faster, the prodrug fosphenytoin can be given at a similar but at a higher rate. It can be given 150 milligram per kg. The dose is similar as 20 milligram per kg, and there is less problem with the extravasation and necrosis. So fosphenytoin if available, but it's costly. So these are the two agents which where the seizure will where It will prevent the further episode of seizure. Once these two has been given and still the patient doesn't respond to the second line, then there is high chances that patient may land up in status, and early escalation to anesthetic treatment is now recommended. So second line agents which are used for seizure, which are under study, is valproate, levetiracetam, and phenobarbital. Now if you are using phenobarbital 20 milligram per kg, around 1000 milligram, if the airway is not protected yet, now is the time you have to protect the airway. Patient will require endotracheal intubation. It might turn out to be difficult intubation, so you have to have expert help besides, and all preparation for difficult airway. Levetiracetam can be given at a dose of 20 milligram per kg, 20 to 60 milligram per kg. Valproic acid, if available, can be given as 20 to 30 milligram intravenous. If the patient don't respond to this second line agent, then the chances of progressing to the status, patient has to be shifted in the ICU, of course, and you have to start the anesthetic agent. The most common one is the midazolam infusion, which is 0.2 milligram per kg bolus and 0.2 milligram to 0.6 milligram per kg per hour, or a propofol with loading dose of 2 milligram per kg or 2 to 5 milligram per kg per hour. Now these drugs, depending on the patient's hemodynamic status, depending upon the monitoring status, you have to decide the anesthetic drug, either midazolam, propofol, or going to the pentothal, that is 5 anesthetic drug 5 milligram per kg to induce a barbiturate coma in resistant cases and treat as 1 to 5 milligram per kg per hour. You should know the what to monitor during these drugs. When these drugs are being given, the patient is to be monitored through continuous EEG monitoring ideally, and you should try to achieve the burst suppression. Now midazolam has a tendency to have a long half-life of it after it is given as a long context sensitive half time, and propofol, you should monitor the risk of rhabdomyolysis, metabolic acidosis after 48 hours, 24 hours. There is a risk of this condition causing cardiac depression, renal failure, hypotension. That is propofol infusion syndrome you should be aware of about. So when you are giving these drugs, you should monitor for these adverse events which may happen. And the meanwhile, you are using these drugs, ketamine, though earlier it was thought to be the stimulant, but now it is well-defined studies as a anti-epileptic drug. So when you are using these drugs, you have to monitor the EEG for burst suppression. So what is the burst suppression target? Here you see that it is for 1 to 2 second burst of cerebral activity interspeed by 10-second interval background suppression, and these drugs has to be continued for 24 to 48 hours before sedation is lightened. During this time, when you are doing this anesthetic drug, what you have to do is increase your maintenance of anti-epileptic drugs to therapeutic or sometimes even supratherapeutic doses, so that by the time when you lighten these drugs, anesthetic drug, your level of anti-epileptic drugs oral you have achieved and prevent the recurrence of the problem. Not to understate the importance of ancillary ICU care while these patients are receiving anesthetic drugs. Patient is on ventilator, so your ventilator bundles, your propped up position, your ancillary care, feeding of the patient. Patient is bedridden to prevent thromboembolic prophylaxis, ulcer prophylaxis, glucose monitoring, and bladder, bowel, and back care has to be taken care. Selection of antibiotic depending upon your local flora. There is no role of empirical antibiotic, but if there is aspiration. Try to avoid the quinolones, which are the drugs like which can lower the threshold of seizure and has interaction with anti-epileptic drugs. Look for the various drug interactions in this particular patient to avoid secondary complications and to give the basic nursing and ancillary care to prevent secondary ICU complications. So, in conclusion, the treatment of status epilepticus, which is important neurological emergency, should start with the awareness in the community regarding early activation of emergency medical response 108, awareness regarding the positioning of the patient, regarding giving the midazolam spray if the primary response is available, early initiation of treatment with benzodiazepines, in ER use of algorithm based approach as per the availability of drugs and local protocol to avoid treatment delay, and monitoring with EEG has becoming a very important tool of practice in the neuro ICUs. What is in the future? Rigorous studies for safer anticonvulsant drugs. Lacosamide, which is 200 to 400 milligram IV, is appearing as a second line agent as a limited data but promising in resistant cases. The development and validation for dry electrode EEG devices that can be easily applied by the trained technologists are also essential to not to miss out on cases of non-convulsive status epilepticus. So that's the treatment protocol and the uh, any feedback. Thank you for your listening, and I'll be happy to take any questions or feedback on this mail. Thank you very much.